Welcome everyone to the fifth session of CIHR's 2020-2021 Patient Engagement Lunchtime Learning Series, Assessing Readiness to Engage. Unfortunately, usually we have closed captioning. It's not available today, but the YouTube recording will have captions, and we will share a link to slides using the email you registered with. You are welcome to share your comments or questions in the chat at any time. The main session will be recorded and uploaded to CIHR's YouTube channel, and I've put the link in the chat there. And I will turn it over to our presenters.
Thank you so much, Trish. Thank you everyone for joining us today. I think it'll be a good session, and we're going to talk a little bit about assessing willingness and expectations around engagement and getting all prepared. So maybe we can switch the slide. So first of all, I wanted to start off by acknowledging that we as the presenters are gathered here today on Treaty 1 land, home of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and homeland of the Métis Nation. And in coming together today, we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. We recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, and government systems. And we dedicate ourselves to moving forward in partnership in a spirit of reconciliation and collaboration. And in talking about patient and public engagement, I think, and community engagement in health research, in fact, it's Indigenous research methodologies that are really at the forefront, and Indigenous scholars, researchers, communities that we should be looking to. And as far as patient and public engagement in research is concerned, it's our firm belief that it must be rooted in health equity and social justice. So because this lunchtime learning is accredited by the Royal College of Physicians and Surgeons of Canada, we wanted to disclose that both myself, Carolyn, and Ogai are employed by the George and Fahey Center for Healthcare Innovation. So let's just take a quick review about what our learning objectives are for today. So by the end of the session, attendees should be able to describe the importance of conducting readiness assessments prior to engagement, describe key concepts of assessing internal and external readiness, and then conducting readiness assessments in planning, patient and public engagement, and health research decision-making. So we got lots of big expectations today. So let's get into it. So first of all, we wanted to make sure that we are all on the same page, because I know sometimes there's a lot of different terminologies that we use. But for our sake, we're going to look at the Canadian Institutes of Health Research's national initiative known as the Strategy for Patient-Oriented Research, and how they define patient-oriented research. And it's seen as a continuum of research that engages patients as partners in decisions about the research process. It focuses on patient-identified priorities. It improves patient outcomes, and also is conducted by multidisciplinary teams in partnership with relevant stakeholders, and it aims to apply the knowledge generated to improve healthcare systems and practices. So if you notice, I bold and capitalize "and" because it is a continuum of research that incorporates all 5 of these elements, and we should always remember that. And again, we'll just look at the Canadian Institutes of Health Research, SPORE, Strategy for Patient-Oriented Research, definition of what is patient engagement. And so it's defined as people with lived experience being involved in the governance of research. So having patients, caregivers, community members on actual research teams, on steering committees, in the priority setting of research, in the conducting of research. So having people with lived experience can be involved in being co-interviewers or collecting data in different ways, and then in the knowledge translation of research. Another great way involves sometimes is research that is carried out with or by members of the public rather than to, about, or for them. And for us at the for us at the Center for Healthcare Innovation, where am I? I should just say we typically say people, informal caregivers, families, and communities with lived experience of health conditions having a say in decision making about the research process. So having a say in identifying the priority area, clarifying and defining the research question, identifying outcome measures or outcomes that should be in the research project, co-developing the methods and the design of the research, conducting and analyzing and interpreting the data, and then also in the knowledge translation aspect. And some of the core beliefs that, that underlie engagement of patients in the public and health research is that it will improve the health outcomes and enhance our healthcare system. It'll increase the quality and the appropriateness and the acceptability and transparency and relevance of research. And it'll ensure that health research addresses issues of importance to people with lived experience of a health condition.
Well, thanks, Carolyn. I'm going to take the next few minutes to highlight and share some information around the different levels and methods of engagement. So patient, public, and community engagement in health research and/or healthcare systems projects are often viewed by many public organizations, for example, the Patient-Oriented Research or Patient-Centered Outcomes Research Institute, as existing on a continuum. So at the one end of the continuum, we have minimal involvement in the decision-making power and feedback on the research and/or project process, to the opposite end, where the patient and public and our communities have complete involvement, and we see patient and public as partners with decision-making power. So the level of engagement may change depending on the stage or phase of the research project. So that is, patient-public partners may be engaged at a higher level of decision-making during one phase of your project than another. For example, patient partners may have more control over the research design than data collection in a study. So as you can see on the continuum, there are three levels. There's consultation, collaboration, and patient-public directed. And so taking a closer look at the consultation level, the primary goal is to obtain feedback and or input from individuals, caregivers, community members with experiential knowledge of a health concern. And when looking at the stage of research or healthcare project, so for example, researchers can obtain patient, public, community partners' opinions and feedback on research or project priorities, formulating questions, study project design, collection of data, analysis, interpretation of findings, and dissemination, and so on. So in other words, consultation can be used at any stage of the project. However, at the consultation level, the researcher or the project lead oftentimes holds the decision-making power. So what we mean by that is that folks can provide input and feedback. However, the final decision lies with the researcher or the project team to incorporate or not, which parts and how much of it. And so methods of engagement, there are different methods that can be utilized at the consultation level. For example, surveys, discussion groups, town halls, and these are just a few examples of many more. And some important considerations at this level is to clearly communicate to patient, public, community partners around which research or project decisions they will be informing. For example, research project, priorities, questions, design, data collection, choosing different participatory approaches, interpretation of findings, dissemination of information, and so on. And it's very important to continually inform patient, public, and communities on how their input is being used. Again, it's that whole feedback loop of accountability. And looking at collaboration, the primary goal at this level is that researchers work directly with patient, public, communities throughout the research process, and oftentimes taking place at the beginning stage of the research process to ensure values, culture, experiences, concerns are considered at the research process and reflects the wishes of the individuals you're partnering with. And here the decision-making, we see that it's shared between the researcher and patient-public partners in order to be able to co-create and co-develop together. And some of the methods of engagement, so because it is participatory nature and partnership-based relationship, patient, public, and community sitting on the research team are engaged in full participation in every aspect of the research process, from question identification to analysis and dissemination. And at this level, some consideration it requires is that time commitment, trust, openness, flexibility, resources, adequate planning and preparation, critical reflexive practices, so considering anti-oppressive and trauma-informed approaches to ensure meaningful and authentic involvement can take place. And also acknowledging and addressing power imbalance between the researcher, healthcare practitioners, public and patient partners, and other research team members. And looking closely at the patient-public directed, so here the primary goal is that patients, community, the public, they are the ones that actively control, direct, and manage the research process. So at this level, patient, public, community partners are at the forefront of the decision-making process, and the research or project is driven by the patient, public, or communities. So in other words, patient, public, or community partners decide on the issues to be studied that are of importance to them, hold the funds, and decide how to allocate them accordingly, choose the research design, dissemination, and they also have ownership of the data. The stage of research at this level is that folks are actively involved in the entire research process from inception to implementation. And here we see the decision-making power lies with the patient, public, and communities. And it's important to consider that all decisions about the research and our project process are controlled and made by patients, public, and our community. And the role of the researcher is to support folks in the process. So therefore, it's important to do capacity building around research process, different tools and resources that are available, different methodologies and approaches, and the patient, public, or communities can decide to use or modify the different methods that best fit their community context, choosing ones that are culturally appropriate. So now I'll turn it to Carolyn, who's going to share her knowledge around internal assessment.
Thanks, Ogai. That was a great overview of the levels of engagement. So now, how do we even begin to prepare for patient and public engagement in health research decision-making? And oftentimes we find health researchers come to us with the best of intentions when it comes to engagement. They see the value of having the experiential knowledge of people with lived experience, our patients, caregivers, community. They want diverse perspectives to inform their research decision-making, but just aren't quite sure where to begin. And what you'll find is a lot of different organizations, whether it's the International Association for Public Participation, among others, really highly recommend doing both an internal and an external assessment of expectations and willingness to engage in order to better understand at what level both the researchers and are willing to share the decision making with people with lived experience, but also the expectations for involvement and engagement from community and people with lived experience as well. And this is kind of the initial stages, so it's going to help you decide what participatory approach to use, how to engage. All of these questions, getting those at the forefront. So internal, we will start with internal assessment. That's usually what we recommend, but sometimes we find people will do kind of simultaneous internal and external to gauge. But for our purposes today, we're going to talk about internal assessment first. And I thought we would actually, typically we jump right into the research team or the researchers and what kind of their internal assessments are. But I think it's really, really important to first do the personal work. And this means both researchers and our patient partners to have to ask themselves a few questions and to reflect on these before we even get to the team internal assessment. So first of all, we want to think about what are my own personal values, experiences, interests, beliefs, and political commitments in the area of health research we will be researching. There's times researchers say to me, well, you know, people with lived experience come with a lot of political, their agenda and stuff like that. We need to understand researchers do too. Researchers bring their own perspective as well, and their own viewpoint and political interests around an area of research, and that has to be explored in a reflexive way. We also want to think about how do these personal experiences relate to larger social and structural locations in which I inhabit. So this is called positionality. Everybody, including researchers, are not objective entities. We inhabit many different social locations, so gender identity and expression, race, ethnicity, indigeneity, socioeconomic status, age, ability, sexual orientation, importance, immigrant status, religion, all of these different things affect the way we perceive a research question, a way we look at research problems, and even define what a research problem is. And so these are socially constructed locations that we inhabit, and they actually are connected to larger processes and systems of power and oppression. So patriarchy, colonialism, racism, capitalism, transphobia, ableism, homophobia, xenophobia, sizeism, Satanism, all of these different things. And so it means we personally sometimes inhabit social locations that give us unearned privileges and sometimes unearned disadvantages. And so it's important to do that critical reflection first before we engage, so that we understand how that affects the way we look at things and how our perception is around a research problem and the things that we're going to have to personally and internally address ourselves. And another question we always ask is, from your perspective, what current health inequities? So when we say health inequities, we mean avoidable and unjust inequalities in health between and within groups of people. What health inequities exist in the area of research that we're going to look at and that we're going to have to address within our research and within our engagement strategy, right? Also, what are my personal values, assumptions, perspectives, and experiences with regard to people living with the health condition in which we will be researching? So this is for researchers, but also people with lived experience too, because sometimes when we're living with a health issue, we may perceive our experience as the experience, but understanding that our experiences exist within all of these different contexts and that people may experience health issues differently. And so understanding how our perception of that might be. And then what are my, so then we go into our heart-to-heart amongst research team and even amongst people with lived experience who may be on the very, very initial research team before we kind of expand and engage more community members. What extent does the team believe that patient and public engagement will improve the outcome of the research and or project? So it's really important to think about, as a team, our belief at how much this will have an impact and be on the same page. What's the real potential for people with lived experience to actually influence decision-making within the research process? So when Ogai was speaking about the different levels, you have to be honest about whether you're going to be sharing decision-making power or whether you're going to be consulting people with lived experience, but in the end still making the final decision. And being really clear about where you're at is important, because you have to be open and honest as well with people with lived experience who are being engaged. It's also good to have an understanding about how flexible and adaptable the team is around research decisions, right? If you are asking people with lived experience to co-design the methods, you need to be open and flexible to people saying, you know what? I don't like that strategy. I think we should go a different way, and being open to that, or the outcome measures aren't relevant to us, or even the question itself needs to be changed. So how flexible and adaptable are you? And what is the likelihood that the team will fully consider patient and public partner input? If people say something completely different, are you willing to take that and run with that and be flexible? And I know it has a lot to do with funding as well. And so it's really important just to lay that out first. And then what resources, both human and financial or monetary, are available to support patient partners involvement. If you remember one of our previous talks with Trish around budgeting for engagement, thinking about compensation for people with lived experience for all of their insight and contribution, thinking about covering expenses, but also thinking about how availability to support, to be able to go for coffee and do things with people. So both human and monetary resources. How much do we have available to effectively engage? And that's really going to help you decide what participatory approach you're going to use and how many people are going to be able to engage. And then, of course, the lovely things like timelines. So we know it takes time to engage, and for people with lived experience to process information, to be able to authentically share and research decision making. And so understanding what your timeline is and where there are areas in which people can truly engage. Training, do researchers need more training around engagement? Do community members need a little extra support around research processes and learning a little bit about that? And then outside of compensation, are there other benefits that you might be able to offer to members of the public? Letters of support or reference, training, conferences, public speaking opportunities, all of those things as well. And then always being mindful of the sensitivity of the research topic area that you're doing and the overall societal context and its implications for the team. So really starting to do that, that critical reflexive work around it as well. And these are ones that I always think with research teams too, just to have an understanding of the research problem that you're looking at. How was it decided upon? Did we involve people with lived experience? Who's missing? But also, what are some of the assumptions that we might have about the causes of the health issue we are researching and which populations are affected, and underlie, and all of what these assumptions underlie the representation of the health issue that you're looking at. So taking a good hard look at the research you're thinking of doing as well. And then thinking about who framed and defined the health issue in that way. Why do you think they framed it in that way? And do you think that people look at the health issue? Has it changed over time, historically, or does it differ from different social locations? And then also, I think simultaneously, as you start engaging externally and doing your external assessment, thinking about how you think people with lived experience in this area would prefer to be involved, understanding what barriers may exist to engagement and some of the challenges and the facilitators. And then one of the things that you know about us, I think we bring this up all the time, but we always think it's an important thing, is thinking about the issue of trauma and how it may affect the area of health in which we will be researching. So remembering not only like things like interpersonal violence and those types of forms of violence, but also thinking about trauma that may be induced from the healthcare system, and also larger systems of power, thinking about racism, intergenerational trauma, colonialism, sexism, ableism, homophobia, transphobia, all of those different things and how they may impact the area that you're looking at, and also then the engagement that you want to be doing with people with lived experience. So we thought we'd take a pause because we're going to move into internal assessment with OGAI. But any thoughts coming up right now? Are there things that maybe we missed? And we'll give you a second to look, to write in the chat box before we move. Oops. Why is mine?
So yeah, if you want to share in the chat about what kind of internal assessment considerations have your teams done? What do you think is really important to think about for the research team when assessing your readiness to engage?
It's a big question.
And maybe as folks are thinking about some their own experiences to share with us, I can go on with external assessment, but we'll keep an eye on the chat box to make sure that we don't miss any of your valuable knowledge. So thanks so much, Carolyn. That was very insightful and lots of questions for all of us to think about when we are engaging internally. But looking at external assessment, it's highly recommended and valuable to conduct external assessment by having transparent and open conversations with patients, public or communities with experiential knowledge of health condition you would like to engage with in their surroundings before beginning to plan your engagement strategy. So your team will have a better understanding of the external expectations and willingness to become involved. For example, things like previous history of engagement. So historically, research with diverse communities was conducted without including community partners in a participatory way. This resulted in community members feeling that research has been conducted on them rather than with them. And also some populations have had very negative experiences with researchers in the past and may have hesitations and uncertainties about becoming involved in research. So some questions that you can think about in asking communities is that, has there been a history of patient-public community engagement for example, in previous projects by research team members, in projects about the same area of health research, and so on. And if so, what were the outcomes and experiences for patient, public, and community partners? So these questions are important as it raises awareness so that you and your team can engage in an authentic way that fosters trust and relationship. And that happens right at the beginning as a first step. And one thing that research teams can often do is to build that initial trust and relationship is to attend gatherings in communities and let people get to know who you are, not as a researcher, but on a personal level, and vice versa, to start some of that relationships. I'm just going to take a pause. Is there any comments on the chat that I need to be aware of?
I think there were just a few comments. Did you want me to read them?
Sure, yeah.
Ham was saying, any suggested format process? Do you recommend self-reflection followed by discussion? Okay, did you want me to? I think self-reflection is always an important, but an ongoing thing. So doing it at the beginning and then continuing to do it. And I know we will provide kind of a one-pager afterwards to everyone who attends that has all these questions and kind of how you can work through them. Karen says, I find that sometimes people lack confidence, but with help can get to the point of being ready to engage. Heather says, how to ensure this process is done with enough depth and reflection, recognizing we usually come to this process with the best of intentions, but still have blind spots. We don't see what we don't know to look for. And that's a really, really good point, Heather. It's a ongoing process. We never truly know, but it's good to keep that dialogue going. We got, sorry, okay, we got lots going on here. Colleen, I think this is completely necessary and should just be a given. How ready do you think our current local healthcare system is for patient-engaged research? That's a really, really good question. And Carrie says, often your patient partners may point out those blind spots, especially if they feel comfortable in their partnership. Oh yes, Carrie, that is so, so true. I think we've all had that experience that if you build a good relationship with trust, that a lot of times people will. And then, Karen Denise mentions, thank you for this presentation. CHI led research of provincial incident management practices following COVID. I would suggest research will be needed following wave, but but research that engages frontline providers, patients, residents, clients, and families would be extremely valuable. That's a really good point as well, Karen. So this is excellent, excellent. We've got some good conversation going on. And Ogai's gonna walk through now and walk through all of that, those great things that you were talking about externally.
Well, thanks so much everyone for your comments, and keep on coming, because this is the only way we can learn is together. So I guess moving on, another area of external assessment for consideration is to assess and gain deeper understanding of external inequalities that exist and have an impact on individual, community, and societal level. And Carolyn touched base on that previously, which may have rippling effects and cause barriers for patients, public, and community partners who you would like to engage with. For example, some assessment questions you can ask may include who is affected differently by the health condition. So being mindful of the social determinants of health and how individuals' membership in a targeted social location, for example, socioeconomic status, ethnicity, mental health, age, ability, and so on, may face more adverse effects. You can also ask questions of who has different access to services, programs, and interventions. So reflecting and having an understanding of what factors may cause individuals and communities to be faced with barriers accessing services. Again, looking at structural and systemic barriers, for example, racism, colonialism, sexism, classism, ageism, and also depending on geographical location, so looking at urban versus rural, may have different access. Where are people at with their health condition? So consider people who may have recently developed a health condition, as well as those who have had it for years and those who have recovered or are in remission. So engagement may be more appropriate or feasible at different times, depending on the condition, and also depending on where folks are in their journey. You might divide people in different cohorts or group when doing your engagement with the group. And as a team, how can you ensure diverse perspectives are included? So creating opportunities for folks to voice what they define as barriers they are facing from their perspective, and how do we support break those barriers so diverse folks have the opportunity to engage. For example, providing childcare, honorarium, translators, covering transportation costs, for example, having bus tickets, choosing accessible locations, or ensuring that rural folks can attend engagement opportunities via online mode of communication, or setting meetings within their own communities. And also building relationships and connections with diverse communities to ensure recruitment includes diverse voices and perspectives. And this is so important. Manitoba, there's so many diversity that exists. And if we want to make changes for Manitobans, then we need to have diverse Manitoban voices to be part of research and shape those solutions. And so not only is it important to have and be aware of barriers and risk factors faced by many individuals and communities, but equally as important is to be aware of the strengths, skills, values, and resiliency that individuals and communities have. So as part of their protective factors, and this is why it's so important to have patient-public partners as part of your research team, so that research brings about solutions that are context-based and culturally appropriate in collaboration and partnership with individuals whose lives are being impacted. And moving to the next slide. So the following are some questions that can help assess readiness and level of engagement. Again, asking individuals and communities with experiential knowledge of the health condition, what are their concerns and priorities? What are their expectations? What's important to patient, informal caregivers, families, friends, and communities? For example, what did they identify as needs-based community context, cultural knowledge present? And also, at what level people expect to be engaged in research projects, and how would they prefer to be involved? Do they want to be at a consultation level? Would they rather be at a collaborative level, or are they wanting to do patient-public directed research? So the best way to choose which engagement methods and activities are most appropriate, inclusive, and desirable is to have open dialogue with patients, caregivers, communities, and ask how they would like to be engaged. For example, would they rather be part of a discussion group, one-on-one interview, arts-based activities and methods, conversation circles, and so on? And what types of roles would patient-public community partners like to take part in? So sitting on a steering committee or advisory group, conducting interviews, or co-facilitating focus groups. And so once you have recruited patient, public, or community as partners, it is important as a team to go through the following questions so inclusive engagement can take place. For example, what do you think are some of the ways in which we can make sure everyone feels safe and heard when working together on this project? What does physical, psychological, emotional, and cultural safety mean to you, look like to you, and feel like to you? Have open discussions with patient-public partners around terms, meeting times, locations, communication preferences. And also working together, how can we become more aware of and take advantage of opportunities where we can challenge each other's ideas and renegotiate power within our project team to ensure all voices and perspectives are equally shared and considered? And what are the roles and expectations from the researchers? And what are the roles and expectations from patient-public partners? So now we're going to open it back up to all of you. So we know that we don't have all the answers. The more we engage communities, the more we engage individuals with diversity of backgrounds, the more we learn and what to include. So if you have, from your experience, not only as a researcher, but as a community member, as a patient partner, what are some questions that we should consider? What are some factors that we should keep in mind when doing external assessment?
It looks like there is one good piece of advice. Engage patient partners as early as possible, set objectives, roles with lots of humility and respect. Patient partners are most often less intimidated and much more secure to collaboration than lots of clinicians and researchers. And please do not be paternalistic. Those are
That's great.
very good from Sylvain.
Thank you. I think oftentimes we keep saying it, the earlier, the better it is, because it helps you form everything right from the beginning. So again, just feel free to comment if anything comes to mind as we're going through. I think, Carolyn, it might be
what happens, and this does happen, when you do an internal and an external assessment and they don't align. So for example, you might have researchers who are kind of at the consultation phase, but they still want to hold some decision-making power, and people with lived experience saying it's collaboration or bust, right? We're going to share decision-making or we're not going to engage. So it's really important during those times to have those conversations that Ogai was talking about, and really get a good understanding of the expectations and the values of people living with lived experience, and making sure that you address that gap. Sometimes we find that there might be opportunities to build from one level to the next throughout the research project. So sometimes we may start at a consultation level and then slowly move to a full collaboration level as we get more comfortable with one another and we start talking about the expectations as we move forward. So it's really important to take the time to understand what the community expectations and values are, to challenge yourselves as researchers too around letting go of some of the decision-making power and how much you're able to, investing time, as Ogai was saying, in building relationships and trust outside of the relationship project, or outside of the research project itself, but working, meeting together, going for coffee, having ongoing conversations to build the relationship. Seeing if there are opportunities for different levels of engagement at different phases and stages of the research process that can meet both internal and external expectations, working together to kind of navigate that. And I think the final point is committing to an ongoing dialogue around expectations and willingness to engage. This is really important. Are we meeting everyone's expectations and continuing to have that conversation? Do people feel like it's shared decision making, or are we slowly moving backwards? And having an understanding of what success looks like from everyone's perspective. It's always really good at the very, very beginning to have conversations of what success would look like for us. And it may be very different, you know, from patient partner perspectives. It might be, you know, whole system changes, right? We want to see something come out of this research. And for researchers, it may be kind of trying to build on a next grant and trying to move things. And so having those conversations and being really honest and transparent about what we want to see happen in this relationship is really important. And there's going to be times where things don't align, and also being cognizant. I know we've had projects in the past where we did the internal assessment, we did all of these things, and then in not doing a full external assessment, what happened was when it was time to engage, different communities were like, you know what, this is not a priority for us right now, so we're not ready. And so also respecting people's wishes to decline or to not engage, or that there is another priority area for people as well, is really important. Respecting those limits as well.
Thanks, Carolyn. It's really important for us to talk about COVID-19 pandemic and how we've moved most of everyone is doing their engagement online or on the phone. So since the inception of the pandemic, we have seen, again, this shift in research collaboration and engagement with patient, public, and community partners, which has quickly moved to online spaces. So we need to slow down and reflect, and as a team, on ways we can work to create safe and inclusive spaces online. So we encourage open and honest conversations within the research team around capacity, funding, timelines, and creating a plan of action to address patient and public partners' needs and mitigate barriers to involvement. So once the team has internally assessed their ability to engage meaningfully online, they need to speak with patient and public partners about how they want to be engaged and identify their needs to be able to fully and meaningfully participate. So some important elements that I will be sharing with you all was identified by the members of our collaborative partnership for research teams to consider when working to create inclusive online spaces. Our patient partners have written a blog that shares more in-depth information around these topic areas, as well as presented in a panel in one of our webinars, which you can access through the YouTube channel. So one of the topic areas was sense of belonging. So having a sense of belonging is a human emotional need, a desire to be part of something that's greater than oneself. So the majority of patient public partners join research teams with the goal of making a difference through research. So patient public partners that we have the privilege of working with have expressed how physical distancing has created social isolations for many, and more than ever need to create a sense of belonging. So this may mean calling up a patient public partner and asking how they're doing, with the sole purpose of connecting rather than discussing the research project issues or progress. What we do here at CHI is that every Friday we have scheduled a half an hour for patient partners to connect with us and each other through Zoom. So it's also a great way to continue to build trust and relationship by continuing to get to know each other. And safety and confidentiality is really important when you're taking your engagement online. And most teams are using accessible platforms such as Zoom, Microsoft Teams, or WebEx with video capabilities. And this may pose challenges or hinder patient partners' participation. For example, some people may have, not a quiet space or a private space in their home, and maybe sharing space with loved ones or roommates in close quarters. And patient public partners may not want to disclose that they are a patient partner or have a particular condition to individuals that they're sharing their space with. So this can result in patient public partners not feeling safe to participate and voice their experiences in an online space. Another challenge may be that patient partners not want people to see where and how they live and wish not to share their private space. So we must also consider cultural differences around appearing on video. And these are just a few of many concerns we are raising. While virtual backgrounds or muting video may help to elevate some of these concerns, these are not the decisions that should be made solely by members of the research team. Again, it's important to have one-on-one conversations with patient, public, and community partners around their comfort level and safety and best ways to communicate and share knowledge. The next one is accessibility of online engagement. So not everyone's comfortable using technology and online tools, and we need to be mindful of different skills and abilities when working towards inclusive and online engagement. For example, people with language barriers may have difficulty understanding and conveying their thoughts in the language used in engagement activities. For example, in-person meetings, folks might be able to talk and take the time to share nonverbal communications or cues and create shared meaning and understanding. And this is quite difficult or even impossible in an online virtual meetings. And even thinking about translators, it might not be as easy as having a translator beside you while you're doing your engagement activities. And some people share knowledge through stories and require physical connection with others to fully convey their perspectives. Another important area is that some patient partners are hard of hearing, have difficulty seeing, and or have neurological or other physical conditions that limit the amount of time they can spend in front of a screen. So one of our youth patient partners expressed how almost all youth are familiar with using different apps and technology. This does not inherently mean that they are familiar and comfortable with having formal virtual meetings. And I'm conscientious of time, so I'll try to go as quickly as I can. So some examples for accessibility supports that you might think about is having closed captioners or subtitles so people can read. Record the session, of course, with permission, and sending materials and slides ahead of time so people can review. Being flexible, so consider using visuals such as whiteboards, allowing people to annotate slides or share screens using breakout rooms, and taking time to establish as a group some ground rules or principles of working together, and follow up with people individually to see if they require additional information, and if possible, having translators. Again, it may not be as easily as having a translator in person. And I'll quickly do the access to technology. So again, technology has been a great tool for most of us to be able to stay connected and continue our work safely from home, but this is not the case for everyone. So before setting up online meetings, it's important to have an understanding of the barriers and challenges of using technology to connect. For example, in rural and remote areas, and even within urban centers, there may be limited to no internet access or cellular reception. So network connections may be reduced both in rural, remote, but also in high density areas such as apartment complexes. And as a result, individuals might experience choppy or lagging videos and audio, making it difficult for patient partners to follow along and contribute in live online conversations. And some people may be limited to using their phones to connect virtually and experience barriers with being able to download, install, or run video conference apps. Some patient public partners may only have access to older technology and experience similar barriers with using apps and online tools. So here are some suggestions. Dedicate a portion of your research budget to providing technology, such as tablets or phone cards, so individuals can partake in the engagement. Providing instructions and direct support to use online technology and video conferencing. Having meetings dedicated solely to establishing comfort and safety. And if you have materials for review, send them by mail so people can sit there and actually physically review them. And I'm going to take one more minute because I know we're giving you so much assessment questions and it can seem so overwhelming, especially in this time. And we recognize that researchers, you're human, and the COVID-19 can impact you as well. And your well-being is important to be able to do a good job when you're doing research. So limit the number of engagement activities to 1 per week. If possible and feasible for patient public partners, conducting meetings and interviews or discussion groups in the morning. even for patient partners, because it gives you a whole day to access supports, debrief, rather than having a nighttime where you may not have access to a lot of supports and a lot of places may not be open. Taking breaks between engagement activities to allow time to process and reflect, and incorporating scheduled debrief and informal sessions with your team, and keeping a journal just to have your thoughts and not keeping it inside. Thanks so much.
Thank you.
I was just gonna super quickly, thanks Ogai for that. There were a few comments that I'll just really quickly go through in the chat box. Carrie brought up an awesome point around the importance to keep engaging people throughout the entire process. So sometimes there's gonna be lulls, maybe it's a period of time where there's data being collected. So making sure you have a plan and a strategy to keep connected with people and to keep that relationship going in the meantime. Another great point Pam pointed out, and this is something we see a lot too, is not having money at the early stages of a research project to be able to do some of that external assessment and building the relationship and getting people's feedback. The one thing I know here in Manitoba with the Center for Healthcare Innovation, we actually developed a funding grant to allow you to get a little pot of money to do all of that early engagement, like priority setting and figuring out what the research question is, to then move on and try to get a larger grant. And I know I think there are a growing number of support units in every province. So I would definitely check out, if you're not in Manitoba, check out your support unit there to see whether there might be some of these funding awards that you might be able to apply for that will enable you to engage at the really early stages of the process, just building that relationship. And I'm just, there's Karen sharing lots of really good resources to people. I think we had a question. Oh, Heather asked, can we talk about how this looks different from new partners versus those we've collaborated with in the past? Because some of the questions are challenging. That's absolutely true. Some of the questions are challenging if they're new relationships versus the ones that we've kind of already established. I know Ogai, a lot of times we have one-on-one conversations a lot with our newer members just to work through some of those questions so they don't feel put on the spot in a big group of people who may have been engaged for a long period of time and are kind of used to it. So maybe taking the time to have some one-on-one. Do you think?
And also just to add to that, maybe with older patient partners or communities, we might have initial relationships, but it's still good to have the same kind of assessment questions because situations change for people. Health conditions change, people might experience new barriers. So it's always good to keep that in mind too if they're new or older members. The only difference would be you might have already established some trust and relationship.
That's a really good point, Ogai. And when we were talking about kind of benefits that we can offer people with lived experience outside of monetary, Heather also said co-authorship and co-presentation at conferences can be of value to some partners, or being designated a peer researcher on a project so they can put on their resume or CV that you're part of that as well. Those are great suggestions. We got lots of good suggestions today in the chat.
Yeah, because a lot of times when I've engaged individuals, for some honorarium does help. For others, it's building capacity. Maybe they want to know how to be a co-chair and build those skills as well. So keeping the opportunities open and again, having conversations of what do they identify that they would like to be compensated. So